focusing on bipolar
So
endoscopy.
this cadaveric workshop is dedicated only
Of uniportal endoscopy,
unilateral
biportal
UBA,
endoscopy.
that is biportal endoscopy.
So we are not
is,
going for
evolving.
the
So we are doing
we are focusing on
disc
biportal
herniation, far
endoscopy
lateral disc
only.
herniation by using para UB. We
So
are
the,
doing
the
cervical
range
disc
of,
herniation, lumbar canal stenosis.
uniportal
Now
endoscopy,
we started doing
that is
endofusion
UBA, that is
using
biportal
this
endoscopy
biportal
is,
endoscopic
evolving.
technique. So we are doing the UB technique for
disc
the
herniation,
far
lateral
lateral disc herniation by using para stenosis. We are doing cervical disc herniation, lumbar canal stenosis. Now tomorrow we will be covering
started doing
endofusion
using
this biportal
endoscopic
endoscopic
in the
technique.
thoracic UB.
So we will be covering the UB technique for the
So the about the
canal
UB
stenosis
is and
if
initially
time
we
permits,
started
we
with
can go
open
for
surgery,
para-UB.
then
And tomorrow we will be
get
covering
together on
the
tubular,
cervical,
then we get
UB
to uniportal.
and,
Now we are
if time
shifted to
permits, in the
biportal
thoracic
endoscopy
UB.
system.
So it is an adaptation from the arthroscopy system where we use a fluid
So
medium.
the about the
so
UB,
that clarity
UB
of vision
is
and we
initially
take the
we
advantage
started
of
with open
endoscope.
surgery.
So
Then
with the fluid
we
medium
as
get together
normal
on
saline
tubular,
clarity
then we
increases
can
tremendously,
uniportal.
and
Now we are shifted
with
to
biportal
biportal.
endoscopy system.
We have
So it is an
a
adaptation
free hand
from the
maneuverability
arthroscopy
so
system
that,
where we use a fluid
as
medium.
we are working
So
under
that
clarity of
under,
vision and we take the
biportal
advantage of
endoscopy, we
endoscope.
are working
so
under the
with the fluid medium
and we
are
as
very
normal
close to the
saline, the
target
clarity
organs. That is the
increases
main
tremendously.
advantage. And with biportal
So before we
have
start
a
this course,
free hand
we
maneuverability
will have
so
a
that
brief introduction of
as
the
we are
faculty
working
and
under
the delegates.
microscope under biportal endoscopy
myself
we
is
are
Dr.
working
Rajesh
under the
Kumar
fluid
Meena. I
medium
am working as
and
an
we are very
additional
close to
professor
the
in the
target
Department of
organs. That is the main
Neurosurgery from
advantage.
2016.
So I started
Before we start
working
this
with,
course, we will have a
microscopic,
brief introduction
spine
of
surgery,
the faculty
then
and the
shifted to
delegates.
tubular. Now
So
I am shifting to
myself is
biportal
Dr. Rajesh
endoscopic.
Kumar
So
Meena. I am
also
working as an
learner,
additional professor
like
in the
you.
Department of Neurosurgery
So any
from
queries
2016.
you can ask.
So I
dedicated
started
faculty,
working
Dr.
with
Rahul Ahluwalia,
microscopic
and Dr. Dattara,
spine
Dr.
surgery,
Deepak, then shifted to
Grawal sir.
tubular. Now I am shifting
And a
to
word of
biportal
caution
endoscopic. So I am
from my
also
side that
a learner,
before we start
like you,
endoscopic surgery,
so any
you
queries
should be well
you can
versed with
ask
the anatomy,
dedicated faculty, Dr.
microscopic
Rahul
anatomy.
Ahluwalia,
Otherwise, it will
and
be
Dr. Dattara, Dr. Deepak,
little difficult
Grawal sir.
because in endoscope we will see we have only
And a word of
a
caution,
small part of
from my
the
side
anatomy that
before
is
we
visible.
start,
you will be see only
endoscopic
lamina,
surgery.
you will be see
You
only
should be
facet
well
joints.
versed with the
So if you are not
anatomy,
well versed with the
microscopic
anatomy,
anatomy,
you will get
otherwise
lost and you will get
be,
frustrated. So
before starting the
because in
endoscopic
endoscope we
course,
will see we
especially
have only
biportal,
a small
you
part
should be
of
well versed
the
with
anatomy
the
that is visible.
You will be see only
Microscopic
lamina,
anatomy
you
and
will
you
see
should
only
have
facet
done
joints.
at least
So if
10
you
or
are not
15
well versed
cases
with
of
the
open
anatomy,
surgery.
you will get
For-
lost
to
and you will
understand
get
the relevant
frustrated.
anatomy.
So before starting the endoscopy course, especially biportal, you should be well versed with the
We have invited faculty Dr. Rahul to guide us and our course director Dr. Deepak Agrawal sir, who doesn't require any introduction. Myself Dr. Dattara Savarkar, I will be around to help you guys. And I mean this invited faculty has witnessed this workshop guide us and our inception director Dr. Deepak Agrawal sir, who doesn't so when we started, just for your myself Dr. Dattara Savarkar, I will be around to help you guys. And I mean this lab has witnessed these workshops since its inception 2014. So when we started, just for your
If you go on the internet, you will see series of growing up with the time. We started our previous first workshop with, open approaches, open pedicle screw fixation, then MI approaches, missed discectomy. Then if you go on the internet, you will see series of workshop on easy go and destined do. We have our that time's heroes, Dr. Rohidas coming for the destined do, Dr. Yadav took so many workshop on easy go, and we are still growing with it, right? Then it come like we had series of workshop on Uniportal, and then for last 3 years, with Dr. Park's involvement and other our faculty, we have developed into the UB. So I mean, we ourselves are growing, and what we practice, that's what we try to preach. Now, not a commercial activity or just to something, to identify what is relevant, what is going to stay in future, and what is going to help you all. With our experience, we are there for you for all things, and we'll keep all the logistics available so that you understand the intricacies between all these approaches. Because if you start as a beginner in endoscopy, you can convert it into the open, you can go to the MI. Similarly, if you do some advanced things, you have CSF, you have to go into the open. So I mean, this is interchangeable. For patient, if patient on endoscopy, then it's okay. Otherwise, for you, if you can give a best result with any approach, it is still okay. But now you should know what is in the trade, right? and it's our job to teach you. So we are all available to guide you and welcome you all. So we can have a brief introduction. So what is expected from where you are, which specialty you are, and what is your experience into endoscopic spine surgery and endoscopic skull surgery also.
Good morning, sir. My name is Dr. Parth. I am from Noida, AIIMS, and we recently started doing endoscoping spine past 5 months.
The Uniportal. Oh, perfect.
I am Dr. Praveen Kumar Tripathi, Associate Professor Neurosurgery from AIIMS Bareilly, and I am practicing endoscopy since last 7 years, cranial endoscopy, pituitary and other endoscopic procedures. For spine, I have just tried once or twice, and I am doing tubular microscopic procedures and tubular fusion, etc. for 6-7 years. So hundreds of cases in that.
Nice to know that. Very nice.
I'm Colonel Anand Gupta. I'm doing only microscopic surgeries. I have never done any endoscopic spine surgeries, though we have done some TNTS with the help of ENT guys, simple pituitaries. Yes.
Myself, Dr. Hanuman Prasad. I am Assistant Professor in the Department of Neurosurgery at King George Medical University, Lucknow. And I myself doing cranial endoscopy, like pituitary surgery, TNTS, as well as colloid cyst, ETV, and C-separanuria. And in spinal endoscopy, we are doing AGGO system, and not frequently, but we are still doing. So we want to learn new technique like UV.
Myself, Dr. Anuj Chavda. I am working in a private sector in Karnal. I have no experience with endoscopy in spine, but I did open surgeries mainly. Neuro.
I am Dr. Sanjay Kumar. I have done my MCH this year, and I am as a bonded AP in Cancer Institute, Kalyan Singh Institute in Lucknow. And as sir said, I am here. I am also here to know the endoscopic surgeries of spine.
Very nice.
Good morning. I'm Dr. Devesh Singh. I'm an assistant professor in orthopedics in United Medical College, Prayagraj. I have been doing open spine surgeries and also the arthroscopic surgeries in. So it is better if I can do UB also and my arthroscope also. That's the main motive too.
Very nice.
Good morning. I'm Dr. Sunil from Bangalore. Novices, total novice.
No? No, okay, no.
I am third year resident, neurosurgery resident from IPGMR Kolkata. I have seen and done open and under microscope also, seen under microscope, microscopic surgeries also, and no exposure in endoscopy also.
Perfect. Welcome.
Good morning, everyone. I'm Dr. Satish Dere. I'm a lecturer at Jananath Mangeshkar Hospital, Pune. So I came here to learn techniques and how to handle the instrument and learn from distinguished faculty members. And I really thank all the organizers and faculty for their sparing time to guide us. Thank you.
Sure. You're from Neurosurgery, right? Yeah.
Hello, good morning, everyone. I'm Dr. Rakshi Shetty. I'm a neurosurgeon working in Mangalore. I'm a colleague of Dr. Sunil Shetty, sir. So I've been seeing open discectomies since 2008. I finished my MCH in 2013 from NAMANS, Bangalore. I've been doing microdiscectomies, but I have not done any endoscopic discectomies. I'm here to learn all the tricks and trade. Thank you.
Hello, good morning, everyone. I'm Dr. Sachin, Assistant Professor in Neurosurgery, JJMC, Karnataka. I don't have any experience in endoscopy, but I practice only open procedures.
You are from ortho, neuro. You do cranial endoscopy? Perfect. So why I have asked two important things to demystify certain things. I mean, once you start doing it, you will realize that how easy it is or how simple it can be. Really, if you are doing cranial endoscopy, what Dr. Rahul will be teaching you here, what we will be teaching you in the lab is triangulation. What you do in the cranial endoscopy, your triangulation point is sela, right? You use two nostril, which is hardly 2 centimeter away. Your one scope goes from one nostril, other working instrument goes from other nostril. They triangulate at only single point, which sela. If they triangulate at two different points, I mean, if they triangulate at the carotid, you will rupture the carotid. If you triangulate, or if you go anteriorly into anterior cranial base, you will go form a CSF leak. So if you have that anatomy and concept clear, that okay, step by step, I have to find out where I have to land, and I have to work between only this 2 centimeter right? So here there is dry media in UBE, it is you are just operating below, and you have wet media. That's it. If you understand this concept, similarly for those guys who are doing arthroscopy, one instrument and one working instrument. But the whole technique is, if you take your two prongs too away, if you land at the wrong point, you will mess up with your surgery. Either you will drill more bone or you will coagulate more muscle. Our job here is to tell you what is your entry point, how to do minimal dissection, be right on the spot and do your job. If you find over next 2 days, it is so simple. It is so simple. That's why you kept 2 days. This is 1 day's job, as Professor Deepak was so like, let delegates do till their best point. So we have kept today is a basic. Tomorrow also advanced things, means like Dr. Rahul can say on cervical. It's very difficult to emulate cervical UB. So we may not try, or otherwise mess things and get demoralized. We can try a thoracic one, but we can refine our technique tomorrow also on this delegate. So we can work 2 days on refining UP technique rather than making a rotation or something. So 4 people independently can operate at one disc each and enjoy and understand things, so that once you go back, you will really start as a crash course. So this was the idea, to tell you about why it is important. So.
Thank you, Datta. I welcome you all. And as Datta has already said, our aim is that everybody gets ample hands-on. It's a cadaveric course. We don't want to waste time in theory. Theory is absolutely important. So whatever material has been shared on the group, please go over it. Maybe you didn't get time yesterday, go over it today. So when you go back, please read it. So when you come back tomorrow, you're better versed to again do on the cadaver. That is the advantage of again having the second day same thing cadaver. Although theory will be different. We will be showing you the advanced techniques, which if you want later on, you can always emulate. Also, this is the live streaming will be happening. So all in the group, we have shared the link. So you can always go back and have a look at the videos, whatever has been done today.
Over to you, Rajesh.
Thank you, Dr. Datta Raj, for the nice introduction. So we will starting our didactic lecture. So first lecture, I will be talking about the surgical anatomy of lumbar spine. So in this talk, I would be concentrating only what is important for the biportal endoscopy. I am not going into the details of anatomy of lumbar spine. I am only dealing with what is important for the biportal endoscopy. So it is a very concise lecture. It will help you to understand the basics of biportal endoscopy and its relevant anatomy. So as you all know, when we do biportal endoscopy, so the basic thing why it is called as unilateral, because we approach from one side, and it's biportal. We are using 2 ports. One is an endoscopic port and the other is working port. The endoscopic port is for the visualization and the guidance, and the working port is for our instrument. So, and the medium which we use is the normal saline. So that will enhance our clarity. So there is an endoscopic port, there is a working port, and the medium is normal saline, which enhance the clarity. So the working port, the advantage of biportal endoscopy is that we can the increased maneuverability. As compared to the uniportal endoscopy, we get increased maneuverability, and you can for both the endoscope as well as the instrumentation. So we can have a wider versatility and the movement of our hands. So my anatomy is concentrated only on this part. Okay, so when we put an endoscope or so we will be able to see only this part. So if you are not well versed with the anatomy, you will get lost. What to drill, how much to drill. So that will depend upon the understanding of an anatomy. So I will divide my lecture into 3 parts. I will be dealing with the bony anatomy, the muscular anatomy, and the ligamentous anatomy, which were relevant for the biportal endoscopy. So as you all know, the most important concept in the biportal endoscopy is the spinolaminar junction. So what is a spinolaminar junction? A spinolaminar junction is an abratory line between the spinous process and the lamina. So it would be somewhere here. So we dock our working port as well as endoscopy port here so that we can see this spinolaminar junction. So when we follow the spinolaminar junction caudally, we will get to the inferior articular process. So this is the inferior articular process, which we shortly known as IAP. When we follow the spinolaminar junction cranially, we will reach the area which is known as pars interarticularis, which is an important area for the stability. If there is increased stress on the pars interarticularis, there are chances of fracture. So if we drill more bone, there are chances of fracture and we have to fix the spine. So when we follow the pars interarticularis more cranially, we will reach to the superior articular facet, and it will form a superior articular process, and it will form a facet joint with the above inferior articular process. When traced laterally from the superior articular process is the transverse process. So once again, spinolaminar junction, inferior articular process, pars interarticularis, superior articular process, and this is a transverse process. And there is some process over the superior articular process, which is known as the projection, which is known as mammillary process. So it acts as it is a site for attachment for the muscles. So this is a very interesting paper by Alexander, in which he had removed 25% of the pars interarticularis and 50% of the pars interarticularis and compared the stress fractures. So he says the removal of lateral half of pars interarticularis leads to considerable stress increase. So there are high chances of fracture. So how much pars interarticularis can be removed? This is a frequent question asked by the observers or the new delegates. So we can remove up to 25% safely. If you remove more than 50%, there are chances of stress fracture. So up to 25% can be removed safely. So once again, spinolaminar junction, this is the main area where we are dealing with spinolaminar junction. So we will be docking our ports at the spinolaminar junction. So this is the endoscopic port, and this would be our working port. And if we depends upon whether we are operating on the right side or the left side, that will change. So once that spinolaminar junction is clearly defined, we can use that our RFA probe to remove the muscles that are hindering our vision. And once the spinolaminar junction is identified, we will drill the bone and we get into the depth of the bone, and so that our area of working increases tremendously. So while we're drilling the bone at the spinolaminar junction, there are potential source of bleeding, and mainly they come from the superior articular artery or intra-articular artery or inferior articular artery. So we can control the bleeding by RFA probe or by bone wax. Now the third important thing, or the most important thing, is the disc and nerve relationship. So we have to understand, if you are new to the what is the exiting nerve root and what is the traversing nerve root. So for example, below the L4 vertebra, below the L4 pedicle, there would be a nerve root passes under the pedicle. So that would be the exiting nerve root. And when we go medially, there would be L5 nerve root which will be passing below the L5 pedicle. So for the L4 level disc, L4 is the exiting nerve root and L5 would be the traversing nerve root. So this is a very important concept for understanding the next slides or the pathologies of the lumbar spine. So when we see in the MRI, so this cut was taken at the level of L4 disc level. So we can see that at the level of L4 disc, there is a nerve root which is exiting. That is the L4 nerve root. And in the within the dura, there is a traversing nerve root which is the L5 nerve root. So it is very important to learn by heart this concept because it will be very helpful for our surgeries. So based upon the what is the exiting nerve root, what is the traversing nerve root, there may be symptoms of the lumbar spine. So if the disc is of central type or para-central type or the inferior migrated disc, so there are high chances of compression of the traversing nerve root. But if the disc is this migration is towards the superior migration or there is a far lateral type of the disc, there are chances of compression of the exiting nerve root compression. So we have to, depending upon the pathology, we have to tailor our approach. For that paradiscal or the central type of disc herniation, we will be using UBE, and for the far lateral type of approach, we will be using para-UBE. So there is a classification which is known as extraforaminal disc is there. There is a foraminal disc is there. There is a disc in the lateral recess, and there is a central disc herniation. So what is the lateral recess? So this term, when you do endoscopy, will be come to you in everybody is talking about the lateral recess. So what is the lateral recess? The lateral recess is a space in the spinal canal where the traversing nerve root travel before exiting the spinal canal. The traversing nerve root will go, it will go around the pedicle and will be the exiting nerve root. So the space lateral to the traversing nerve root is the lateral recess. So it will be frequently talking about the lateral space in the biportal endoscopy. So there is a concept of Campion's triangle. Campion's triangle is very useful when we do uniportal or transforaminal disc herniation. So it was originally described by the Campion in 1988. So he described a triangle in which the exiting nerve root forms the anterior part of the triangle, and the traversing nerve root will form the base of the posterior part or the superior part of the triangle, and the disc space will form the base of the triangle. So it has been variously modified by various authors. Some says that the superior articular process may be the base or the superior surface of the triangle. So now the next would be the muscular anatomy, which is relevant to the biportal endoscopy. So only the muscle which we will be talking about in biportal endoscopy is the multifidus muscle. So it's a small muscle and it consists of the two fibers, the short fibers and the long fibers. Short fibers arises from the spinous process and the lamina, and they project to the mammillary body. And the long fibers, there are 5 sets of fibers. They also arises from the lamina and the spinous process, and they attaches to the iliac crest and sacrum below. So the one important concept of the biportal endoscopy is the minimal muscle dissection or the no muscle dissection. So we will be dissecting no muscle in biportal endoscopy. We will be creating a space between the multifidus and the spinolaminar junction. So there is no muscle disruption in this type of endoscopic procedure. So we will be creating a space between the spinolaminar junction and the multifidus muscles. And this space is known as Sons space, after a famous North Korean endoscopic spine surgeon, Sons. So we are creating a space which is known as Sons space. So what we are doing, we are putting an endoscopic port, we are putting a working port and a fluid medium. That fluid and the medium is normal saline, which will uplift the muscle and would create the space. So we are destructing minimal muscle damage. So we are not removing the multifidus, we are uplifting the multifidus muscle in our endoscopic surgery. Now the third important structure which after the bone muscle, and third is the ligamentum flavum. The ligamentum flavum is the best friend of a working surgeon if you are doing endoscopic procedures. So seeing the ligamentum flavum under a microscope is a different feeling, and seeing under the endoscope is a different feeling. So they are totally a different point of visualization. In an endoscope, we will be seeing very close to the ligamentum flavum. So understanding the anatomy of ligamentum flavum, it is like a butterfly. It is like a butterfly. We call it as a butterfly. So it has paired structures, which is an upper attachment and the lower attachment. So upper attachment will be attached to the anterior surface of the lamina, lower half of the anterior surface of the lamina, and then and goes up to the pedicle. So it is to the lower half of the anterior surface of the lamina and goes up to the pedicle. Inferiorly, it divides into two divisions, the medial division and the lateral division. The medial portion passes back and attaches to the upper 1/4 of the dorsal surface of the lamina. And the lateral portion passes more laterally, and it goes up to the joint, and it forms the anterior capsule of that joint. Far laterally, it can goes up to the pedicle of the next level. So it is very important to understand this anatomy. What is the limits of the ligamentum flavum? Because in endoscopy, we are exposing the almost. If you want to remove the ligamentum flavum completely, we have to understand the anatomy. We have to understand this anatomy. So it is like a butterfly. It is extending from one pedicle to another pedicle, and it is involving the joint. And there are two layers of ligamentum flavum, which will be demonstrated in the cadaver and will be shown in the subsequent slides. There are two layers. One is the superficial layer, which is known as dorsal layer, and the deep layer, which is known as the ventral layer. So superficial layer is thick, and the deep layer is thin. And the outer layer is attached to the upper lamina and the lower lamina, and it is a wide and a strong attachment at the upper lamina. So it is so we have to drill more bone to free it from the upper attachment. The lower attachment is slightly soft, stuck, and can be easily detachable. So there is a sandwich theory for the safe resection of ligamentum flavum. As you all know that because we are working under pressure, the whiter is at the height around 30 centimeters. So we will be delivering a water pressure of 30 mmHg. So the water will cause the dura to tent inside. So while removing the ligamentum flavum, if we go below the fat layer, so there are chances of including the central fold of the dura in the Carrison pouch. So there are chances of injury. So we have to work above the fat to remove the ligamentum flavum, because of the water pressure, the dura will tent and will form the central tenting of the dura. So drilling of the bone. So how much drilling of the bone is to be done? So we will be removing the inferior laminectomy. We will remove the lamina. So we can see the median raphe, and we can see the epidural space. So that is the first landmark is after drilling of the lamina or the partial laminectomy. The first landmark is the midline. How to identify the midline? Midline is identified by the median raphe, or there is an epidural space which we can clearly see. So that is the first orientation. How far we have to drill, how lateral we have to drill. The first is the median raphe, and we have to see the epidural space. Then we can drill laterally to free the ligamentum flavum, and depending upon the pathology, we can go to the contralateral side to remove the complete ligamentum flavum if there is lumbar canal stenosis, or we can remove only partial ligamentum flavum to remove the localized disc is there. So it depends upon the pathology how much ligamentum flavum has to be removed. So these are the sequence of if you have to do the contralateral lumbar decompression, we have to remove this. So how much bone has to be removed? We have to remove this lamina, partial lamina. We have to remove this inferior articular process and part of the superior articular process of the opposite side. So this is an endoscopic view. We can see this is the median raphe, which is the V collar like shape. This is one part of the ligamentum flavum. This is another part of the ligamentum flavum, and this is the contralateral lamina. When we go to the opposite side, we have to see the contralateral IAP, and we have to see the contralateral SAP. When we follow the SAP, we will be seeing the medial wall of the pedicle. So this IAP, SAP, medial wall of the pedicle will be frequently talked about in endoscopy when we are going through the lectures or we are seeing the video. So you have to understand where is the contralateral IAP, where is the contralateral SAP, where is the medial wall of the pedicle, and what is the lateral recess. So you have to be very conversant with the terminology. So after all the complete removal of the ligamentum flavum, we will be seeing the dural sac, we will be seeing the contralateral traversing route and the ipsilateral traversing route. So this is the final outcome. So the traversing nerve route are very well decompressed. So this is the part which we will talking about when the disc is the central disc herniation or a paradiscal herniation. So this is the classical UBE. So for the far lateral disc herniation, we will be doing para-UBE. Para-UBE is nothing but a modification of the UBE in which it is usually for the far lateral disc herniation, in which we create a space between the transverse processes. So in UBE, we create a space between the spinolaminar junction, we dock here, but in para-UBE, we are working, the working space is between the transverse process. So this is, so we have to make our entry and the working portal and the endoscopic portals lateral to the lateral pedicular wall. But otherwise the working portal, the fluid medium and all things same. But we have to the dock to the different place so that we can see we can remove the far lateral disc. So we have to be well versed in whether this is the transverse process of the upper vertebra, this is the paracentarticular or the isthmus, and this is the superior articular process. So para-UBE, we will be dealing with the far lateral disc herniation. So if time permits, we will be doing para-UBE exercises. If the time doesn't permit, we will be skipping. Thank you for your kind attention. So any queries, you can ask me or you can mail me. Thank you.
Very nice and very elaborate lecture. I mean, anatomy was very clear. What point he has covered from typical surgical anatomy to the practical application into the procedure, which you are going to see. Anybody has any specific query? मैं एक बार instrument 2 minutes में दिखाऊँ. Any queries? Yeah. So, Dr. Rahul, basically, SONS is like, I mean, forget about that. Like we have supraspinous and paraspinous area, right? Between the multifidus, there is an area which is avascular. There is a fatty tissue, loose areolar tissue. So that is the area. That, like we go into the sphenoid cavity, right? We open the face of the sphenoid and then we have you utilize that area to work on the sella. Similarly, arthroscopy, we open things, go into the cavity. Similarly, there is no obvious dead cavity available that you can jump in. You utilize that area between multifidus, that area. You when you dock and you put the saline water in the pressure, that area get expanded. That area where then you start working, it's called SONS, right? He can show you in that.
See, basically what you need to understand is that we have not read the anatomy the way it is being discussed right now. Multifidus muscle is the most important component of UBE surgery, and multifidus muscle does not attach to the lamina. You need to understand this. The attachment is at the spinous process and at the transverse process. It just rests on the lamina. So on an MRI, you can see this T2 hyperintense zone, which is just adjacent to the lamina. If you can, I'll show it on my slides also. So that is known as SONS space. Earlier it was said that UBE is being done by creating a new space. And then it was realized that no, we are not creating any space. Just like abdominal laparoscopy, there is a lot of space. You put in CO2, insufflate it, create more space. Similarly here, multifidus is resting. That is it's a potential space which has loose areolar tissue. I'll show that loose areolar tissue also in my presentations. And it is this space which is expanded. So it's an actual space. It's not a pseudo space. It's an actual space called as SONS space because it was described by Master Son. So it's named after him. It's basically the loose areolar tissue beneath the multifidus muscle.
Nicely explained. So you can see here, So ideally, his statement is, most important statement is, we have not read the anatomy the way we should know it. But that generally we don't do it if it is not needed. We were not doing UB earlier, that thing, that's why we don't know. Similarly, transforaminal, we don't do it, so we don't go for transcambin and all anatomy, right? But once you start doing it, then whole day lecture happens only on that transcambin area, right? So similarly, first most thing, Rajesh, which has pointed out, to know your anatomy, know your area, where you are going to work. And if you know better, then you can utilize all your gadgets and can do good work. But if you miss the anatomy and landmark, like what he has explained through his lectures, midline approach, paramidline approach, UB for discectomy, UB for over the top decompression, similarly UB for extraforaminal and foraminal disc. So these are all on the specific landmark. You have a docking point. If you miss those docking point, then you can create a disaster. Like in para-UB, you go little laterally, you cut the anterior ligament, and patient have all those fluid inside his abdomen, retroperitoneum, right? So I mean, that's why this anatomy is important. So first start with the basics, rest of the things to go. Even people will do it after 30 years, 30 cases. Even for fusion, people will go for initial 25 cases and then go for endofusion. So go step by step, but what you are going to do after 2 years or after 25 cases, the genesis lies here, that you first start understanding it and then you start applying it. So thank you, Rajesh, for a very nice lecture. I mean, he can share the slides, or this lecture is available to go back again and see the anatomy. He has nicely compiled all the anatomical points at one places to understand it, right? And another point is, when I was wanted to show you, see, now the instruments, I myself, over 10 years, when we went through all variety of procedures, like we had workshop here on transforaminal as well. We had a scope, but then that even transforaminal requires specific instruments, long drills, different RF. If you don't have one instrument, then your rest of the gadgets get, useless. So uniportal, transforaminal, are so many things require a specialized instrument, and if one instrument get damaged, then you will get stuck up. This is not the case for the UB. You will find simple instrument. If you don't have one instrument, you can really create, or you can go ahead with the other instrument. Only thing required is that you should need a drill. That is also a replacement. If you don't have a specialized drill, you can go for the another options. You can use normal carisons. And second most important thing is needed is only one thing, is either RF, radio frequency ablator, or plasma. That is the only other device, specialized device is needed, not otherwise. And then we have so many things in the market, which goes from cheap to, if you want to be having very branded, to the very costly one. So again, to start the journey, forget about any other endoscopes and things. I'm going to tell you simple instruments. What it needed? Either 0 degree or 30 degree scope. Similar for the arthroscope, right? And similar for the endoscope. We use 18 degree, 18 centimeter. 180 mm simple scope for the endonosal. This is 160, 170. That's it. Simple scope. So if you have Destandu system, you can use that simple scope for your surgery. Right. So it is just another scope. And for the beginner, it is better to be with the 0 degree scope. For advanced thing, once you get hang of it, then you can utilize this 30 degree scope, which require little manipulations. Another important point is, what you need, a scope sheath. In cranial also you utilize the sheath. Similarly here also you utilize the sheath. Sheath help you to protect your instrument, one. Second, sometimes scope sheath has this, like Dr. Park uses this transparent. For arthroscopy we have this metallic one, and it has the curved tip at the things. This help you to do utilize it as a dissector. It helps you to as a retractor. Your scope is there, but if you rotate with your finger, and then that soft tissue which is there inside, that can be taken care of. How to maneuver that Rahul will show you during his demo, and will help you during the procedure. But again, sheath is not mandatory. I mean, if you have control of the things and you can directly put without the sheath, only that scopes cannula is needed. Second one is the working port. Again, arthroscopy, like most of the sheaths will have, this is Dr. Park has specialized, he made it transparent so that it has cocked way and it stays inside, right? So it stays inside. But I mean, rest of the time it is a half C-shaped variety of the length thing, so that just to maintain the outflow of the water. It doesn't have any other role to literally guide you in the surgery. It's not something actually a port, but it is just to keep your working port open. So another third most important principle beside anatomy and this simple instrument is your outflow channel should be good. So the scope forms your input channel, and once that spaces get created, whatever you do work there, that water should be going out freely. To make sure that should go freely, this outflow port or the working port will help you so that this whatever debris are there are washed out. So your another important thing, if you don't have your port made well, then you will struggle during your surgery. So most important thing, you coagulate, some turbid things happens. If your flow is good, it will be get cleared. I'm putting this in your mind so that now next couple of hours you will see that how it practically works. That is one of the most important hurdle. Otherwise, this is can be replicated about anything, right? Another instrument, these are, I mean, if you see here, these are simple curettes, normal and angle that we utilize in the open. Then your simple scope, you have angled and plane carisons, which generally normally we utilize, because you are working in an endoscope, and as you are with the endoscope, you are seeing extra into the foramen, so you require some slender and instrument so that can go as a curved. Third one is like simple open type of small curettes, different angle. Then you have striker or any other local made, like you have drills and shaver which work under the water, right? And as you can see, that's it. Nothing else is required. So these are the burr. They have like conical and normal burr for the cutting burrs on the bone, like we do in the open, and diamond drill when you are working near the dura. That is one. If you are working into the opposite side of the foramen, you can have this conical burr if you are available. Then rest of the drill and shaver are similar, as we are routinely utilizing it. Then another instrument is like you can see this, once you create an incision, create a working port, you utilize this T handle for creating a space. These are another important to strip off the some of the muscle in that area and utilize while docking your scope and working port. Then you have tubular discectomy and all other distensive and easy-go system. You have serial dilator to create a space so that you can put your scope and working channel. So you have serial dilator, working serial dilator, scope sheath. Then you have this angle curettes and dissectors. You have working port here. You have T handle. Then you have again like metallic working port if you want to utilize, and curved nerve retractor. These are the simple, again shown in the different way, like how just like one simple and the curved forceps, rotatory punch. You have curved punch to work under the foramen or while doing over the top decompression, and different kind of chisel. So now orthoscopy guys generally knows it like how to utilize simple. Sometime when you cannot use the carison, or sometime when you cannot drill, sometimes it is very easy to get some portion of SAP out with the only one small stroke using the chisel. So we'll utilize chisel also today. And then third most important thing is radio frequency. This is the basics of it. And uniportal generally has variety of different kind of slender instrument going in different direction. Here it is simple, and then there are some curved instrument. If you have that, your job is done. Variety of setting for different plasma and RF setting, but the basic idea is when you are on the bone, you can cut, ablate and coagulate at the higher level, so the higher level, and when you come to the dura, don't ablate at all because that current can get transferred to the nerve. Only utilize coagulation at the lower point. That we can adjust depending upon machine to machine. This is another OT setup. I mean, if you are generally like in UBE for the discectomy and over the top decompression, we stand on the left side of the patient. Right-handed person stand on the left side of the patient. Your all other instruments like your video equipment will be on front of you. Your C-arm will be coming from right side. Similarly, your everything will be on the right side. Anesthesia can be on the head end, and your trolley and instruments will be on your side, like left side of the patient. This is simple OT setup. And third important point is inflow of the fluid. I mean, this is we use the TURP sets, and that 3-liter saline bottle should be at least around 3 feet above the patient's head level, so that it maintain enough pressure to keep that space open. So this is the only logistics available. I think it is very simple, recreatable, cheap, not doesn't require any other specialized instrument. Thank you. And we will showcase all those things during surgery also, to specially one instrument rather than spending 2 time, because the anatomy was more important. Rahul can take his next topic.
Good morning, everyone, and really thankful to the organizing committee over here for having me here. It is an honor to be presenting something at AIIMS. I would like to first say that I started my journey in spine endoscopy in 2019 after I finished my MCS neurosurgery from IPGMER Kolkata, and I started with transforaminal surgeries. But then I realized that I'm missing something. I know earlier it was said that you could do stenosis with transforaminal approach, and I was like, no, it's not possible. And actually it's not possible. You are going anterior to the disc and anterior to the thecal sac, and then talking about removing a structure which is posterior to it. So that is when I went through certain YouTube videos and I purchased a set and I ventured into biportal endoscopy. I have experimented a lot in the field of biportal endoscopy, and trust me when I say this, earlier I used to believe that it is a very expensive technique, it is a very expensive venture to go into, but with the spectrum of equipments that I have seen that can be safely used for this surgery, I have realized that if you have 4.5 lakhs in your pocket, you can start this procedure in your setup. It is not very expensive. It is a marketing gimmick where people talk about buying a plasma or buying a radio frequency ablator. Trust me, ConMed manufactures a underwater cautery which orthopedicians will use for their shoulder surgery. I have done more than 100 cases with that cautery and nothing happened. There was no neural damage. So don't worry about that the equipment is going to be expensive. It is not. It is very cheap. Yes, you will require certain special equipments dedicated to UB, just like the sheath, the trocars, the dilators, the shaver system that you'll require. You'll need a good drill. I did my first 50 cases with the small ENT micromotor. It was very slow, so the surgical duration was long. So then I finally shifted to a underwater drill system. So I would like to start my talk. This is the hospital where I'm currently working. It's a 250-bedded multi-specialty hospital. So this is the way spine surgery has evolved. Look, open laminectomy, transdural approach, external approach, microsurgery, the tubes, and then into the modern endoscopic era where we talk about the transforaminal approach, the monoportal interlaminar approach, and the biportal approaches. Now, this is a scar for a conventional spine surgery. We don't see this anymore, I'm pretty sure. Now, this is technically a scar for a microdiscectomy or a bigger tube when it's put in. But look at this. This is the scar that comes out in a biportal surgery. Just a single stitch in both the ports. And I'm telling you, once the suture removal is done, 2 months, 3 months down the line, you can't trace a scar. But apart from what is seen outside, it is more important to understand what happens inside. We've been talking about the multifidus muscle so much right now that I would really like to ask a question. What is the role of multifidus muscle? Can somebody actually tell me what is the main role of this muscle? Everybody's been talking about it. Anybody amongst the delegates, can you tell me what is the main role of multifidus muscle? I heard most of you are doing spine surgeries, putting in tubes, doing a microdiscectomy. But honestly, what is the single most important role of multifidus muscle? It is to maintain an erect posture. It is not a supportive muscle. It is one of the main muscles to maintain an erect posture. So whenever you are doing a microdiscectomy or whenever you're putting tubes or even doing an open TLIF, post-operatively your patients will keep coming back to you with one simple complaint. Sir, I have back pain. My other pains have gone, but I still have back pain. And that back pain is multifidus muscle caused by to lumbosacral spine, from disc to stenosis, central to extraforaminal pathologies. People have started doing single level IDM tumors also, and there have been case reports of people performing foramen magnum decompression also successfully. Now, it is based upon the expansion of Sonde space, provision of a continuous water cross flow, pristine magnified view because the refractive index of your scope increases underwater, and underwater electrosurgical units. Now, this is what you're talking about. This is what I was saying. This is the Sonde space. This is the lamina, the facet part. This is the multifidus muscle. It rests on the lamina. So this is the space which you have to expand. Now, what is triangulation? The ability to interchange 2-dimensional and 3-dimensional views inside your brain, because what you see on the C-arm is a 2-dimensional image. You have to be able to generate a 3-dimensional model inside your brain. The MRI is 2-dimensional. What you're seeing split into 3 parts: the sagittal, the coronal, and the axial views. Mostly you take use of the axial views only, but you have to replicate that MRI onto a 3D model inside your brain. Now, this is how you can actually triangulate: an open triangle, a perfect, and a closed triangle. In an open triangle, you will not be able to see the equipment together. A perfect triangle is usually where you see and work comfortably. In a closed triangle, you'll struggle to use your instruments from the outside itself. This is a standard set of markings. This is the markings that are mentioned in the textbooks. I use these standard textbook markings only. This is the midline. This is the disc space. This is the medial pedicle line. This is the cranial pedicle. This is the caudal pedicle. I triangulate all my cases, always. And this is what you see on the C-arm. So we're triangulating at the spinal laminar junction. If you notice, my scopic portal is cranial and slightly lateral to my working portal instrument. This is because I want to be able to see the instrument medial to my scope. A standard set of marking for a 2-level surgery. With experience, you can do 2-level surgeries with a single set of portals also. Now, this is what happens when your triangulation is great. You directly dock into the Sonde space. See this tissue that I'm ablating right now. This is all pre-loose areolar tissue. This is what is Sonde space. You don't see any muscle fiber over here. If you are seeing muscle fibers here, that means your triangulation was wrong. We don't have to damage the multifidus. We go transfascicular. That is, sorry, interfascicular, not transfascicular. We go interfascicular. This is followed by a standard drilling. So I usually start my drilling with a cylindrical Acon burr, which is a cutting burr, and after being able to take care of the surface cortical bone and when sufficient cancellous bone is exposed, I shift to a 4 mm diamond burr. For cervical surgeries, I use a 3 mm cutting and 3 mm diamond burr. Now the posterior drilling, that is the part where the surgery becomes similar to a tube or a microdiscectomy. Now this is from one of the initial cases performed by me. This is a complete decompression in a patient of stenosis. You can see the clarity you have there. This is the ipsilateral root. You can see the disc space also over here. You can see how the sac has been completely decompressed. This is the contralateral portion. You can take a scope here, see the contralateral roots. This is the contralateral exiting nerve root over here, and you can't get this vision in any other form of spine surgery. Now exposure into the cervicals, if you see, this is a young guy with a C5 C6 acute disc herniation. We dock at the C5 C6 interlaminar space under lateral fluoroscopy, and this is a laminoforaminotomy that has been performed. And over here, after drilling the caudal pedicle, you can expose the disc space and take care of the herniated fragments. Another patient, very large extrusion that you can see yourself over here. He presented with cauda equina, successfully recovered after surgery and some physiotherapy. You can see this is the plasma ablator or a RF ablator that we keep talking about. I use this instrument only for all of the dissection that I have to do. I use very minimum number of equipments, and this is my favorite crocodile forceps for removal of a large fragment. What you need to understand is that water gives you an excellent medium for dissecting away the tissues. Whenever we are doing a discectomy, there are a lot of adhesions in chronic discs. Chronic stenosis, you'll have a lot of strong attachments between the thecal sac and the ligamentum flavum. That attachment is called as a Hoffman's ligament. They tend to become tight, and that is the cause of most dural tears. But this water helps us to dissect these things very well. This is I would like to show this video. What you see over here is an osteotomy being performed. The IAP is being resected with an osteotomy, and this is being done for a patient to undergo a fusion. So it completely depends upon you. If you want, you can do the whole procedure by osteotomies. There are people who are not using drills. They will go inside, tuck with a chisel. They'll remove the most of the part of the lamina as well as the IAP and take care of it. It is completely you who has to decide as to how you approach the procedure. This is a video from the same patient. He's undergone a fusion. This is for a grade 2 listhesis. You can see the whole thecal sac has been decompressed. The cage has been placed here with a lot of bone graft. Complete decompression of all 4 nerve roots has been achieved. And when I'll show you during my UB TLIF talk, I'll be giving this in detail. I'll show you the amount of bone work that has been done. This is a video I want to show to demonstrate the actual clarity. You can see clumps of RBCs moving inside the capillaries once your decompression is complete. So now you can understand the level of magnification, the clarity that biportal endoscopy basically brings to you. And to add to it, the best part, see, I do all three. I do a transforaminal, I do monoportal interlaminar also, I do biportal also. With the time when I started biportal, most of my monoportal equipment is just lying around, because biportal gives me the dexterity with a superior magnification. And the best part is I can use instruments mostly which I have in my armamentarium from my routine open conventional surgery days. So see, this is the size of bone defect that you actually make when you're doing a laminoforaminotomy for a ULBD surgery or a lumbar canal stenosis. See, this is the only bone defect that has been made. Thank you.
Anybody has any specific question?
Thank you, sir, for a very nice lecture. Sir, I just want to know a basic question. What is the incision site on the medial pedicle line in relation to the disc space for endoscopic incision and the working port incision?
I'll answer that very nicely to you because see, I'll tell you, when I started, my working portal used to be 1 centimeter in size. Scopic portal would be 4, 5, 6 mm. Slowly with time I realized that I need a 1 centimeter incision on the working port if I'm doing a fusion. If I'm not doing a fusion, if it's a simple discectomy, ULBD surgery, both the ports 4 to 5 mm in size are sufficient.
Sir, I am not asking about the incision side.
Yes, incision site. Site. Exactly like I showed in the image. So the half of the, where I showed the markings, where you see the point where the medial pedicle line,
He has shown there, like what we mark with the X-ray, the disc space, superior pedicle and inferior pedicle. If you are operating at L4, L5, we will mark L4 pedicle and L5 pedicle. So upper incision will be upper half of the upper pedicle, and lower incision will be upper 1/3 of the lower pedicle. So, and then that triangulate near spinal lamina junction.
See, this is the exact site of my incision. This is the point where the pedicle and the medial pedicle line is meeting. This is for the working port. Now half of the incision will come this side, half of the incision will come this side.
Yeah, and this
along this
incision
medial
after
pedicle
2
line.
to 3 centimeter away from each other, paramedian in that lateral recess area means medial pedicular line, and those triangulation happen inside on the bone at the spinolamellar junction, right? And then we work around it and come at the disc level. Yeah, so we'll show you step by step during demo also.
And I'll tell you why I said that this is a standard textbook marking that I use, because I tell you, in India we come across a completely wide range of BMI people, especially when you're in a private practice. You will have some lean, thin individuals as well as some obese. The maximum weight that I've operated is 150 kgs. So when you're using these standard markings, it's not just that your ports will be 3 centimeters apart always. The standard marking allows you to have your ports spaced apart even with thin patients, so that you don't have a very closed triangulation. It's very important to have a perfect triangulation, and that will happen only if you use the standard markings. When you go to different conferences that are being done for UB, you will come across a lot of surgeons who've modified the technique to suit themselves. But that is not why I'm here. I'm here to tell you what is the basic and the right thing to do. Once you've done 50, 100 surgeries, you can modify the technique to suit yourself. That is what every surgeon has to do. But when you're talking about the basics, this is the basic method that you have to follow to start it.
Yeah. So the discectomy incision is at medial pedicular line, right? The fusion surgery incision will be little lateral, 1 centimeter lateral, okay, at the pedicular outer pedicular line. If you are doing para UB, it goes 1 centimeter again lateral, right? When we the way we put the percutaneous screws.
Yes.
So the incision changes as per the things that we will. I mean, when we demo one by one, no, so you can understand. So, if thank you very much. We can start with your
UBT lift off. Yeah, sure.
Yeah.
So it's also important to understand that when you want to do a UB fusion. Now, why fusion? When you venture into endoscopy, most of your surgeries will not require any fixation of fusion. Even doing a 3-level decompression, you will not put in screws. because it is not needed. So where do you land up with fusion? You land up with fusion actually in patients with spondylolisthesis. I have had patients who have undergone their second or third surgery endoscopically. Previous surgeries were microdiscectomies or a transforaminal procedure performed by somebody else. But I did not fuse them because it's not needed actually. True fusions, you have to have instability documented. So you need to understand that endoscopy gives you an edge when you're actually doing a T-lift or a K-lift. With UB, you can actually do a T-lift, that is resect the facet joints as in an open T-lift surgery or an MIS T-lift surgery. You can actually go ahead with a K-lift. Now what is a K-lift? K-lift is a procedure performed by para-UB. That is, you dock on the outside, you drill some part of the isthmus and the SAP, create space and put in a case through that zone. So basically it's a transcambient surgery or a transcambient fusion being performed by a UB method. So what needs to be understood is the learning curve considerations are important over here. So again we are coming back to the Cambine's triangle, which was earlier discussed. One thought that I personally believe in is that we should stop calling it as a triangle, because triangle is a two-dimensional structure. Anything in the human body needs to be in 3 dimensions. So it's rather we consider it to be a pyramid. So that is why the SAP, just like Dr. Meena sir had said, that some people have started considering SAP as the border, some people will call the dural edge as the border. The SAP plays a very important role and acts as a 4th point to create this as a pyramid. And why I'm saying that SAP is important, because when you want to do a K-lift, that is, you want to go from the outside inside into the disc space, the SAP becomes an important. Now the standard procedure for UB T-lift remains the same, that you go inside, you do a laminoforaminotomy, you do a fasciectomy to enlarge the corridor, the IAP is completely removed, some part of the isthmus is removed, and the SAP also is drilled off a little, and your aim is to preserve as much as the neural integrity as possible. Now what are the endoscopic landmarks that you need to understand over here? These are very important: the KIMS point, the WOOS point, and the osteotomy line, which goes from WOO to KIMS. Now I will show it. This is what I'm talking about. This is the KIMS point, the lateral most point of osteotomy, the WOOS point, the medial most point of osteotomy, and this line joining them. It's very important because anything cranial to that will further add to the surgical time and is not needed. This is sufficiently sized corridor to be able to put in a standard cage into a patient. Now, just like Dattara sir said right now, that based upon your target, your markings change. Like when we were talking about ULBD and discectomies, my point of incisions were on the medial pedicle line. Now when I want to do a fusion, I want to be a little more outside. So I'll go from the mid pedicular line, or preferably in the initial cases, my incisions should be on the lateral pedicle line, so that my docking is better and I'm able to come more laterally with my scope to be able to do a good amount of bone work. The most important point here is that the fasciotomy needs to be aligned parallel to the disc space alignment. Again, I'll repeat this. The fasciotomy needs to be in line with the disc space, completely parallel to the disc space, so that you can put in the cage without struggle, without damaging the end plates. Simple steps: you burr the initial part of the lamina. Once you reach the good amount of drilling has been done, you use an osteotome to get as much of the bone graft as possible and expose up to the medial tip of the SAP. Now personally, when I am doing a fusion, I prefer using the drill, and more drilling is done. I use osteotomy only at the IAP to get sufficient graft. Now, the decompression strategy that I follow is ipsilateral laminophromatomy, preserve the flavum, go contralateral over the top, or you can call it an under the cave procedure. That is a contralateral sublaminar drilling, expose the contralateral joints, do a osteotomy there, then come back on the ipsilateral side, complete the osteotomy. Once I am comfortable, I know my bony work is complete, I will remove the ligamentum flavum and I will complete a discectomy and end plate preparation before the cage insertion. Now, this is the video in which you can see this is the disc space over here. This is the traversing route on the ipsilateral side. Contralateral decompression has been done. You can see the contralateral traversing route over here. The neural foramina has been completely opened up. This is the Hoffman's ligament that I was talking about earlier. And once we have achieved this kind of a decompression, the next target is to have a very good end plate preparation. And the best advantage of UB that I found over MIS TLIF is a completely visualized end plate preparation, something which you cannot do in any other technique. It reduces the risk of end plate fractures. It gives you a perfect vision. If you can see this, we are using a simple pen field and we are removing the cartilaginous end plate completely under vision. Your scope is inside the disc space. You can actually go and see up to the anterior longitudinal ligament very clearly. You can't have this vision anywhere. Now, once the end plate preparation is done, we always pack the disc space first with the bone grafts, and here you need to reduce your irrigation pressure to avoid the graft being washed out. You can use a retractor to protect the nerve root, but if you've done a good decompression, good bony work, you can directly put in the cage, just like what I'm doing. So basically now you can see that this is a the video is a little speed up. So this is the cage that is being introduced now into the disc space. This is a standard bullet cage, something that you use routinely for a PLIF or a TLIF. There's nothing new. Your nerve root has been protected laterally. You can use a retractor over here if you want, but I always visualize the root by my scope and see that whether it is free or not. This is the CT image of the same patient who's undergone the fusion. You can see the amount of bone work. The cage is very well placed inside with a good amount of bone graft around it. And this is the three-dimensional. You can just see this is the only amount of bone work that is needed. So it's an ultra minimally invasive technique. After this, percutaneous pedicle screw fixation. You have to ensure the lordosis, final fixation with rods. So it's very important to understand that docking at the mid pedicular line or lateral pedicular line is important, which allows you to do a very good liberal fasciectomy. End plate preparation is pristine in UB. You are able to see completely bare bone, complete removal of cartilage, which gives you a very good bed for fusion. And chisels, standard chisels are available in the set that can be used for osteotomy and get a good graft. Now, the best part that I like is any TLIF will require around 100 to 150 ml of blood loss. That's what's been mentioned in the different scientific studies. UB TLIF, even the blood loss that you do not see because of the irrigation is very minimal. You don't need blood transfusions. Now, what's important to understand is that when you're doing a UB fusion, you're basically maintaining the principles of MIS fusion. It is a safe, reproducible and effective technique and actually likely to become a standard in fusion surgeries. Thank you.
Very nicely explained, sir. So what the topic here was endofusion T-leaf, right? So the incision was on lateral pedicular line or mid pedicular line, and you do over the top decompression. So if patient have listhesis with canal decompression, this is one of the very nice thing. For another thing, if you want to do a transcambin fusion, right? And if there is no stenosis, then you can go little lateral, 1 centimeter lateral to it, and
Yes.
you can go through the extended transcambin approach by removing some SAPs, and then you can directly put it. So just for your understanding, any specific query to Professor? Or is it clear? Great. So thank you very much, sir. I mean, we'll show them during the session.
Yes, definitely, sir.
So these things for next 2 days will revolve around same anatomy, same area. But once you start doing it, then you'll realize that okay, every step is little bit until you get into practice, it is hard.
Thank you, sir, for your excellent talk. Now we will proceed for the inauguration ceremony. So after the inauguration ceremony, we will have a group photograph and followed by TN. And then we will be going for the cadaveric lab. Only the faculty who Dr. Rahul will be starting the cadaveric demonstration of UBE. We are doing the demonstration of UBE only. We are not doing para UBE. So he will be demonstrating UBE on the cadavers. So we will have to sit here. So after the demonstration of the exercise by the faculty, we will be having a lunch. Then the delegates can go in the cadaver lab, which is in the ground floor for the hands-on dissection for the cadavers. So you will have ample of time from 1 p.m. to 5 p.m. You will be doing the cadaveric. So please respect time in the cadaver lab and treat the cadavers as a learning exercise for you, not as a destructive procedure. And there will be 4 delegates per cadaver. So 2 can do on one side and 2 can do on the another side.
Yeah, and our whole team will be available. Dr. Rahul will be there, I will be there, Dr. Rajesh will be there, and rest of the other faculty, Dr. Deepak will be there. Okay. And any problem you can come back to us there, and rest of our team partners are there which are going to help you out. And make sure start slowly today, put all your time in small queries, help each other. It's not that we have 2 days means one is doing for whole day kind of stuff. You have to be on, you have to little bit swift, right? You have to do procedure well. But when you are somebody else is doing, you have to assess it, because then you are learning at 4 points, right? 4 people, one in helping each other. So initially 2 people doing it nicely, helping each other, taking turns. Then another person taking the lead. 4th person is helping him out. That way we can collaborate with you, right? And tomorrow again we will have Dr. Vijay Parihar who will be coming up. We can have another thing also, like we have kept easy go, means like tubular endoscopic system, just to understand that how same anatomy can be visible when we put these scopes or instrument inside, right? So this is not for the demo as such, but for on the each table you will be having that to just utilize different logistics to understand similar.
So we will starting our inauguration ceremony. So I invite Professor Sharad Chandra sir, who is the chairman for this workshop. We welcome you, sir. Next, I invite Dr. Kamran Farooqi, who is the chief of trauma center and the chairman of ACSST lab. Sir is just coming. Next, I invite Dr. Deepak Agarwal sir, who is the workshop director for this course. Next, I invite faculty in charge of ACSST lab, Dr. Vijay Sharma sir, to so now I invite Dr. Dattaraj to please felicitate as a welcome to the chairman of the workshop, Dr. Sharad Chandra sir. Dr. Neha to welcome Dr. Deepak Agarwal sir. Dr. Datta to welcome Dr. Vijay Sharma sir. So lamp light. So we will be starting. So welcome all the dignitaries. Now we will starting our lamp lightning ceremony to begin for this workshop, to have a blessing of Lord Saraswati for all of us.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणाभरदण्डमण्डितकरा या श्वेतपद्मासना या पातु सरस्वती भगवती निःशेष जाड्यापहा
I invite Datta sir to please welcome Dr. Kamran sir with a Now I invite Professor Sharchandra sir, the chairman of this workshop, to have a word of appreciation and for the success of this workshop, some few words.
So good morning, everybody. I think the winter is just setting in, and I think this is the best part of season for Delhi. So on Professor Kamran, Chief of Trauma Center, Professor Vijay Sharma, who is the chairman for this cadaveric lab, Professor Deepak Agarwal, Dr. Dattaraj, Dr. Rajesh, Meena, Dr. Rajender, and all the other delegates here. Good morning to all of you. It's indeed a great pleasure and also a sense of pride that we have been able to conduct these cadaveric workshops so regularly. And I believe these workshops have a lot of things to be learnt, because these are the niche areas and these are highly focused areas, and some of them are highly emerging areas, which I think should become the bread and butter for all the neurosurgeons. Now, lumbar canal stenosis and lumbar disc is something which I believe every neurosurgeon and neurosurgeon trainee should know. And UB, with this regards, UB is a very nice upcoming technique. I believe our equipment is still under process, but hopefully we should get it as early as possible. And this workshop should be a foundation and should expedite our own equipment as early as possible. So I thank Dr. Rahul Aluwalia and Dr. Vijay Parihar for having come here as faculty for this workshop. And of course, we will look forward for many such interactions in future. Thank you.
Now I invite Professor Deepak Agarwal sir, who is the workshop director, to say a few words.
Thank you, Dr. Rajesh. Thank you. All the dignitaries on the dais, Professor Chandra, who's the head of Department of Neurosurgery, and Dr. Kamran Farooq, the chief of the center and chairman of this ACCST lab, Dr. Vijay, who's heading the ACCST lab, and obviously Datta and Rajesh Meena, my co-organizing secretaries here. I see a lot of familiar faces, especially from our neurosurgery department, who are passed out. And I think this UB workshop is something which is now much more in fashion, if I may say. People also demand endoscopy surgery. And because UB is the way to go, we all need to learn it. And we are in a learning phase. We have yet not accumulated that kind of expertise that we become trainers. And I think that is why Dr. Rahul is here as an expert in his field. And the best part is that we see people coming from tier 2, tier 3 cities who are doing excellent work and in their various domains. And there is no shame in learning from anybody who is better than you. And I think that is why we have an excellent mentor in Dr. Rahul to guide us and to train us in this UB. So I welcome you all to this workshop, and we hope to have a great learning experience in these 2 days with us. Thank you.
Next, I invite Professor Vijay Sharma sir, who is the faculty in charge of ACSST lab, to say a few words.
Very good morning to one and all. All the dignitaries on the dais. On behalf of ACST, I welcome all of you for this. I think it's a super specialist kind of cadaveric workshop. I'm sure you're going to learn a lot. I appreciate effort of faculty members who have come from, and what exact timing. Your talk was like exact, it stopped at time, I think, on time. I really appreciate that, and it was very good. Even I was learning from you. So I think for the delegates, I welcome you all, and I would like you to at least look at ACSST site. So there are over 11 courses from neurosurgery, basic, intermediate, and advanced. All courses are there. Like we are orthopedic surgeons, so we have 14, 15 courses. So I have one request to the faculty, Dr. Chandra and Dr. Deepak also. We just had one master class last week, sir. So that was attended by, like you said, faculty needs to be trained also. So we had one master class in which only faculty was there. So it was a 1 day lumbo-pelvic fixation, marginal impaction. So like in pelvic acetabular surgery, 4 major topics and only case based. So we used to put one case and then faculty members used to decide what exactly needs to be done, and then one person used to stand up. And then on cadavers it was just specific faculty based training exercises on cadavers. So it was a very big success. Another thing is like every month, almost every month, Dr. Deepak Agarwal, I congratulate and I have compliments to the neurosurgery team. Almost every month they have a big course. So if you want a very big course like pelvic acetabulum, we have annual international course. So we do it in dissection hall with 12 cadavers. So I think you should, because so many courses, we are doing so many good courses. So if you want to do it on a bigger scale, I would strongly suggest, and obviously you are part of ACSC, so we are going to help as far as cadavers are concerned. So I would suggest one big course should be there, and you should make it some sort of annual course. So I request all the students to give their full 1 day to the cadaveric course, and maybe live surgery also Rahul will be doing. And my best wishes to all the organizers and to the course. Okay, thank you.
Thank you, sir. Now I call upon chairman of the SCCST lab, Dr. Kamran Faruqi, who is the chief of this trauma center. And I thank him for providing this excellent opportunity, state-of-the-art facility for the cadaveric workshops. Sir.
Thank you very much, Rajesh. I won't take much time. The only thing is, being myself a spine surgeon, there are two things I want to say. That I am very happy that Dr. Deepak Agarwal, who is a professor here and leads the neurosurgery department at Trauma Center, he's very, very active in organizing these regular cadaveric courses. I mean, we are very fortunate that we have a cadaveric facility here. I mean, all of the people use it, and under Vijay, it's it's running very, very efficiently, and probably we start ever since I took over and Vijay took over as the cadaveric in charge, we've been doing these regularly. So I do give full credit to Professor Sharat Chandra and Deepak Agarwal for thinking out these very pertinent and relevant courses in today's times with respect to spine. I mean, I've seen over the years he's been organizing these cadaver workshops which are very relevant and I mean in tune with the times and pertinent, especially with respect to I'm not sure about the neurosurgery part of it, but with respect to spine, I've seen all the workshops which are conducted actually in sync with the current times with requirement. And even like as a spine surgeon, I've seen that especially UB now coming up in a big way. Like last, I think, say 5 years, a lot of people are picking up in UB. Earlier it was Stando, Uniportal, but now UB is picking up quite, and I do feel that probably UB has more versatility. The Stando which we used to do, I think it's uniportal as well as unilateral. So I think probably the accessibility is not that much, although I'm not doing it, but I feel that UB, a lot of people are picking up, and I do Scopy also, so I know, I mean, I think the spectrum and the range with UB is far more. It can be employed, but you just need to learn the skills, and this is one of the best opportunities, like first cadaver, practice in the cadaver, get the basics right, and probably that you can keep increasing the complexity of your surgical procedures as you gain more expertise. So, but it's a very pertinent and relevant workshop in today's times, especially with respect to spine. So congratulations Deepak, congratulations Rajesh and Datta, and thank you so much.
Thank you, sir. Now I would like Professor Chandra sir to felicitate Dr. Rahul Aluwalia, who is our course faculty for this course. So I will also like all the faculties, all the dignitaries to be there. So I invite Dr. Dattaraj for the vote of thanks for this workshop. And then we will be having a group photograph and followed by tea.
Thank you very much, Rajesh. I should be very much thankful to Kamran sir, Vijay sir, Chandra sir, and Deepak sir for giving us this opportunity again and again, prove ourselves, learn again and again from the scratch, and keep doing things for the future. So thank you very much, sir, for this great opportunity. And this is the only thing that's like I keep learning, I keep young myself, right? And thankful to my co-colleague, Dr. Rajesh. He's, second half, you can say that. So we work together and nicely, we can coordinate things up. Professor Rajinder sir, we have seen his surgeries since microscopic to the endoscopic, and we have learned from all those things, and then we are ready to teach the other delegates. So thankful to all my teachers and these dignitaries for sparing their time for us and coming here. I should thank you all, guys. In short period of time, you make efforts. I was talking to the Sunil. What is your name? Praveen. I asked him he has just registered for the observer. I said you should, coming from Bareilly, you should register for hands-on, man. I will give it. No. This is my slow process. I will just want to get overview of it, which Dr. DA had planned earlier. Some people wanted to have just overview and they would then want to slow progress slowly. So thank for all of you. And one of our delegates from Yemen, he was there in the course with the Rahul last time, and still he is here. So thanks to all of you. Because of you, this course is alive, and we can do it, and we can teach you, and subsequently we can benefit all our patients. Beside that, our organizing team, backhand team, led by Neha, Vinay, and rest of the teams, thank you very much. Our audiovisual team, led by Ravinder, and we should be very much thankful to our event partner into the sense the instrument that you will be utilizing today will be from Microneurosurgery, Indian company, and the bonds. So they will be providing all your drills, gadgets, endoscopes, so that we can work on the cadaver. Without them, it's actually just not possible to conduct the workshop. So I thank you all of them for providing this support. And with this, I close my remarks, and we can join for the group photograph here, please. Thank you. So we'll now break for 50 minutes. We'll be there for ideas and we'll come back. Meanwhile, we'll sit up.
हेलो चेक चेक हेलो हाँ जी ऑडियो आ रहा है
सिंगल ही है सिंगल चला डबल चला नहीं है ठीक एक ही जाना तो इसके ऑक्स 2 दे दी ना इसमें हाँ तो मॉनिटर बंद कर तो मॉनिटर तो बंद कर बाद में बंद कर देना हम लोग 767 एल के लिए मैं चेक पॉइंट
हेलो
आनंद आ जाए आ रहे बोलो हेलो हेलो हेलो
हाँ ठीक है बोलो बोलो
हेलो
ठीक है
Hello. Check, check, check. Hello.
Hello.
CM आप दिखाइए.
Hello, Anuj. Hello, Anuj. Auditorium. Auditorium.
हेलो.
हेलो.
हाँ जी.
हॉल में आ गए?
हाँ क्लियर है.
ठीक है, बात करो.
ओके.
अगर आगे तो बात करो, सर्जन को मैक लिख दिया.
वो expose हो जाएगा. क्यों काट लेंगे? प्लेट नहीं है यहाँ पे.
Hello. Hello.
प्लेट 11 नंबर देना ना.
15 नंबर.
15 नंबर तो लगा दिए.
क्या क्या वो वहाँ रख दो, मैं बताता हूँ. ठीक है, अभी नहीं लगाना, वो लंच के बाद के मैं बताता हूँ जरा.
ये वाला मत लगाओ.
ये वाला नहीं.
सफिशिएंट लगाओ, इससे भी काम हो जाएगा.
हाँ चलो ठीक है, बढ़िया.
लेकिन थोड़ा ड्रिप काटना है ना.
एक मिनट एक मिनट एक मिनट. अरे सीजर दे दो भाई. ना, बिना सीजर के तो
So till they are setting up the drapes and all these things.
कितनी हाइट काफी है?
हाँ, इसी में बढ़ा दो आपको.
So we will be beginning by showing the instrument tray, then the position of the patient,
यहाँ पे.
यहाँ ऊपर.
then also the drape.
हाँ यहाँ पे कर दो.
चल ठीक है, उल्टा आने कोई दिक्कत नहीं. यहाँ ले लो. इधर.
Hello. Dr. Dattaraj. Hello.
डॉक्टर दत्तराज. हेलो.
Hello. Dr. Dattaraj, are you able to hear me?
Yes, yes. अरे.
Okay, okay. So, Dr. Dattaraj, till the drapes, you will be providing the drapes?
Yeah, we are just, am I audible?
Yeah, you are clearly audible.
Very nice. So we are just preparing things, we are putting a drape. अरे यहाँ पे focus कर देना.
So can you show the drapes, the special drapes for this endoscopy procedure?
Yeah.
This is a laminar spinal drape that will be putting on the. This is a laminar spinal drape. It is available with most of the institutes, and we'll be putting it over here on the cadaver's spine.
वो drape, हाँ.
So since endoscopy, we have to do lot of normal saline and all, lots of fluid is there. So to avoid the seepage, so there are special wraps. So they will cost around 1,000 to 2,000 rupees per drape, and some drapes have also the suction, which is connected bilaterally. I think this drape also has a suction with it.
अरे यार इसने तो ये
So it will connect the suction, and whatever the extra fluid,
Bro, camera
it
में-
can be sucked out. Otherwise, what happens during the procedure, because during the beginning time we are using lots of fluid, so it will get seepage along the drape side, and it will cool the body. So that will be harmful. to the
अमित इसकी
patient.
स्ट्रोकार का दिलीप
First, there is a demonstration by the faculty. Then there would be lunch, followed by hands-on.
कैमरा दिया
ये ड्रेप्स उसने अलग दिया शायद से यार
हाँ ये सारा दे दिया
हाँ
इसमें सेक्शन लगा देंगे सर
हाँ हाँ
सेक्शन
चलो हाँ ठीक है
प्लाज्मा कनेक्टर प्लाज्मा लगा ड्रिल लगा
ये ड्रेप सादा है सर वो अरे वो उसने ये भिजवा दी चलो कोई बात नहीं, देख लो एटलीस्ट इसमें हम लगा देंगे
सेक्शन अटैच करना पड़ेगा
I
वो
think
कर
that
देंगे
this is not the proper drape that is provided.
No,
by
this
the
is not
company.
the proper drape.
Yeah.
The proper drape usually has two pockets of transparent bag through which a suction tube can be connected. ये ठीक नहीं है कनेक्ट
राजेश
एरर है
Hello, Datta.
yeah meanwhile you can ask for cranial ड्रेप्स 5 cranial ड्रेप्स yeah
Okay.
इसको check
So
करो
meanwhile, you can demonstrate your
yeah for not for us for the
instrument
daily
only setup.
yeah sure
Instrument.
फुटप्रिंट चेक करो
यहाँ पे दिखा देना भाई
रेड क्यों दिखा रहा है अच्छा ठीक ओके ठीक चल हाँ एक मिनट मेरे को
सब लोग आएंगे नीचे
ठीक है ड्रिल राइट बता दो याम कौन दिखाएगा
Scope, अच्छा can you hear me can you see the trolley
Yes, Datta, we can
yeah
very well
yes,
hear you.
I'll show them the
ले लो
I'll show them the instrument 1 minute huh? this one and drill हाँ. As you can see here can you see the drill
ड्रिल हटा दो ड्रिल बाद में लगेगा
huh?
Yes, we can see the drill.
So the diamond drill. So there are variety of attachments from shavers, conical drill, cutting drill to the diamond drill, right? That will show. So one drill. Second is RF. Can you see the lateral pointed tip? ये tip पे focus करना. Zoom करो. Perfect. Can you see?
Yeah, this
Here.
is.
So yeah, this is the plasma. ठीक है. So there comes RF and plasma. Plasma is the better one with more safety profile compared to the RF. Compare when it comes to the heat generation and the dural and neural injury, right? So this is the plasma that we utilize. Generally, this is the one which is common. I mean, routinely utilized. But there comes another tips also where it is little bit covered one. Rest of the things is instrument. You can see here 0-degree scope, standard 0-degree scope, scope trocar or scope sheath. You can see. This is scope. I mean scope sheath. This is outer sheath for the scope or scope trocar. Can you see it here?
Yes.
This sheath is open. This can be utilized to displace the tissue. This is you can fix the length of the scope working length of the scope in the sheath.
सीधा करो सीधा.
Another instrument, this is dilator, minimum, then one level up, another level, and the last one. For scope, we utilize only two, two minimum dilator, 3 mm and 2 mm, right? Enough for to
Yeah,
put
इसको
the
सीधा
scope.
करो ना, ऐसा टेढ़ा है यार ये.
Then come, this is T handle for the dissection of the muscle from the soft and soft tissue from the bone, like lamina and the facet.
पहन लो ना तुम लोग.
You can have this. This is called double end instruments. It increases like decrease. In both end has different level of different dimensions of dissectors. So we call it double end. Hook. These are all normal instruments, right? Chisel. Dissector. This is very important while doing it. ये करना पास दिखाना भाई टिप दिखाओ ना. हाँ. While separating ligamentum flavum from the lamina. Another. Then you have Indian knife.
Indian knife.
हाँ, Indian knife. हाँ. You have kerisons and the forceps. So similar forceps. This is the straight one, and the curved one will be more helpful when you are working in the corner. This is Indian knife to do the annulotomy when you are doing a dissectomy. Another kerison, and then sometimes we have curved kerison, which is not available here, right?
So
सामने दिखा देना वहाँ पे. And the arrangement is, we are on the left side. This is the head end of the patient. We are standing on the patient is prone. We are on the left side of the patient. Our endoscopic trolley and C-arm is in front of us, means on the right side, right? Head end, we have the C-arm monitor. Any other thing?
thank you, Datta. Thank you, Datta.
Okay.
Dr. Rajesh sir, can you hear me?
Yes, sir. We can clearly hear
Okay.
you.
So basically, we'll be starting with the markings. So we have the C-arm ready with us. One camera, please focus on the C-arm image over here. One camera, please focus on the body over here. Okay. So can we see everything?
Yes, we can see the
we can
spinous
proceed.
process, and we can see the clear images of the spine,
Okay.
X-ray
Should
images.
please- Okay. So we will be targeting the L4, L5 on this cadaver today. So we mark the midline first. Should please. Should please. Should please. So we're going for the L4.
Ravinderji, can you put the X-rays in the main screen and the? Okay.
Should please. Should please. If you can see, I'm aligning my medial pedicle line marking in alignment with the scoliosis the patient has. Should please. Should. Okay. Should please. Okay. So again, this is the
Ravinderji,
midline.
shift that X-ray
This
on
is the
PIP.
Disc space. This is the medial pedicle line. This is the L4 pedicle. This is the L5 pedicle. Can you see this?
Yes,
Can
sir.
you see
Yes,
this
sir.
part?
Yes,
The
sir.
markings that have been made?
Yes, sir.
Okay. So we now triangulate. Shoot, please. Can you see this marking now?
Yes, yes.
Okay.
So this is for the triangulation.
Like I said, I always follow the conventional marking technique in all my patients. So now we have the incision points for both the portals. This is the working portal. This is the scopic portal.
Sir, do we need a lateral X-ray?
We will go, and now if you see, I'm sorry I'm interrupting you, Rajesh sir. What we were discussing earlier, if you see, both the ports are exactly 3 centimeters apart.
Yes, sir.
So, irrespective of the size of the patient, if you continue following the basic landmarks, you can always have the right markings. Now, as far as the lateral view is concerned, we will first make the working portal. I always triangulate in the AP view. So, we will first create the working portal, insert our first dilator, and then take a lateral view to confirm.
Okay, okay, sir.
So, this is the incision for the skin. Now, for the facial incision, if you notice, I have given the skin incision. After that, I angulate my hand a little in line with the trajectory I have to follow, and then I give a facial incision. Now, this facial incision can be cruciate also. A cruciate facial incision allows for better water egress. So, gives a good outflow to you. पहला वाला स्ट्रिपर कहाँ गया?
कौन सा वाला
रखा था? So this is our first stripper that goes inside, and we just trying to palpate the bone. Shoot, please. Now we'll take a lateral view. The lateral view is important in 2 aspects. Number 1, we have to be sure that we are at the level of lamina. We have not gone into the interlaminar space. That's very important, else we will cause a extensive amount of neural tissue injury.
So we can say the spinous process and we can say the lamina.
Yes.
Okay. Now we are taking a lateral view to confirm whether it is docking on the spinolaminar line or whether it is docking somewhere else. We do all the marking on AP and then we take for confirmation.
Shoot, please.
We take a lateral X-ray.
Factor. Shoot, please. Oh, we are very much out. Shoot, please.
AP. So we are very much out. We are in the
There's a very thick muscle actually. Shoot, please.
नहीं इसका फैक्टर ठीक
Shoot, please. Shoot. Tight muscle actually. Shoot, please. Shoot. Shoot. Okay, so this is at the level of the lamina. Feel the bone. लाइव देना था, लाइव शूट देना। ओके ठीक है, एपी में आ जाओ वापस। शूट देना। तो पीछे लीजिए,
तुम्हारी तरफ खींच लो।
बस अभी शूट दीजिए।
So the first entry is we do it for the working port. We have placed the initial dissector. We strip the muscle. Then we use the series of the dilator at our docking point as you are watching.
Now we'll make our scopic portal.
So as you can see, it is hardly around 2 centimeter above the working portal at medial pedicular line of L4 pedicle.
Shoot please. So they both are inside now. C-arm हटा लीजिए जरा.
Can you see the triangulation in the C-arm? Rajesh?
Yes, 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 very well seen. We can see the spinolaminar junction, we can see the spinous process, and we can see the triangulation.
Yeah. So we are that docking point is at spinolaminar junction just above the disc, right?
Now see, I want you to show over here.
Yeah, perfect. Yeah, यहाँ focus करना.
यहाँ focus करेंगे please.
ये zoom करते रहना.
What I want to show you is the water is going in from the scopic portal and coming out very well from the working portal. Okay? Can you see this?
Rajesh.
Can we see
Yes,
this, Dr.
yes,
Rajesh,
yes.
sir?
Very
We
well
don't
seen, very
say
well
yes,
seen.
yes, we feel that you are gone for the T.
This is called as
Giving
the,
us here.
this is called as a fountain
Suction
sign.
इसमें डालो.
Sheet देना उसमें डालने की.
It's very loud and clear, very well seen. Water is flowing.
Yeah.
हाँ.
So this is, I mean, very good thing. I mean, if your exit working portal or outflow channel is good, then your most of the job is done. Funny.
On करना light source.
उसमें नहीं है, उसने गलत दे दिया.
White balance के लिए देना कुछ जरा. Gauge piece है? छोटा चाहिए यार.
और दो मुझे वो आर्टरी फोर्स भी देना. दो.
चलो मुझे दे दो. White balance करो. कहाँ से? ये वाले से. Long press. नहीं हुआ.
ये पकड़ दो.
ओके अब हुआ. ठीक है. थोड़ा इधर स्क्रीन पे दिखाएंगे इधर एक बार.
चलो. और दो आर्टरी फोर्स.
वो सीन दिखा सकते हो क्या?
हाँ हाँ.
I want you to appreciate that there is a V cut mark that is at the 12 o'clock position. So you need to understand that whatever scope you are using, today we are using a 0 degree scope, 0 degree sheath. So I am approaching from the left side. So my V mark should be at 12 o'clock. That is towards the spinolaminar junction. else I will lose my ground. I will lose my orientation.
Artery forces the neck. Just a minute.
हाँ.
I'm creating artificial rib. At least it has something
Dam
to
बना दो,
support.
dam.
हाँ. Something to support है ना वो, हाँ ठीक है.
इधर लगा दो.
लगा दिया.
लगा दिया.
हाँ चलो चलो लगा दो. हाँ.
So now we'll be going inside. See, I just lifted my scope and I was able to see this. I can't see.
Do you have endoscopic view?
इस जूते से नहीं हो पाएगा.
Yes, yes, we have endoscopic view.
Anup,
Very nice
पकड़ ले.
endoscopic view.
अनूप तेरे पास कर ले उसको. इस जूते में कर नहीं पाऊंगा मैं. येलो करना. हाँ कर. 7-3.
यहाँ का लाइट बंद कर दो.
Off please. Yellow.
बस. So as you can see here, like he
So
is
they have tactile
nicely
feel.
put into the Son's place. Nicely triangulated. You can see outflow channel is working well, and he can see the scope of other working channel instrument in front of his scope, right? And now you have to see how he is working around.
So our first target is to establish focus inside. Yellow please. And after that we have to look for the spinolaminar junction, because that is where we'll start the whole drilling process. This is the lamina.
ये बाकी
Off.
लाइट भी बंद करो यार उधर.
Off. स्कोप पे फॉगिंग बहुत हो रहा है. नहीं ठीक है. So this is the spinolaminar junction. Okay. This is the interlaminar space. This is where we'll start the drilling process. Yellow. Off please. Yellow. Off please. So can you appreciate this bone? This is the bone that we have to drill for the interlaminar space. Dr. Rajesh sir, can you hear us?
Yes, sir, we can hear us. We hear you.
Can you see this bone?
Yeah, very nicely seen. So it is the lamina.
Yeah, yellow.
It is the L4 lamina.
This is the L4 lamina.
Yeah, inferior border of L4 lamina.
Off please. Yellow. This is some interlaminar tissue.
So we are very much in zoomed. We are just above the lamina. We are
Off,
just
please.
coagulating soft tissue over the lamina and interlaminar space.
Yellow please.
Next point will be like we will be removing the upper part or superficial layer of ligamentum flavum, drilling the bone. So I mean your work start. He very nicely created a triangulation and a space.
Yellow. Off, please. This whole bone is visible over here.
Praveen.
Yellow, please. Yellow. Off, please. Yellow.
इस मूर्ख ने गलत ड्रिप भिजवा दी सर्जी वेयर में खरीद के बात करो इस
Yellow. 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 Off, please. So I hope you can appreciate this part. See, I am on the edge of the lamina along with interlaminar space visible. I can also see the phlegm. I'll just remove the scope for cleaning a little.
Yes, sir, the scope looks dirty, so the clarity is not so good.
Yes, yes, yes. So कुछ खड़े होने के लिए मिलेगा क्या?
हाँ हाँ अरे सुनो ये स्टेप दे दो स्टेप 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 फटा प्लेटफॉर्म
Now can you see better?
Yes, sir, very clear.
I just focus a little more.
So another important point is I'm complementing some of the point, like as you can see the bone, right, lamina, interlaminar space, some portion of superficial part of ligamentum flavum is already slightly coagulated. So more and more you go on coagulating the superficial part, this space will get created, right, at the real working space.
ड्रिल लगेगा मेरे को ये आप फुट पेडल अपने पास रखो वो एक स्टेप मिलेगा सर खड़े होने के लिए
हाँ हाँ वो लेके आ रहे हैं
हाँ बस ठीक
और ये
actually this surgery
saline
ultimately becomes taxing on your shoulder, so I prefer to stand in a way that the operative site is at the level of my umbilicus.
Manoj,
so it gives me a good position to keep my shoulder stable. So can you see this drill? This is the drill. It's a diamond 4 millimeter burr that we'll be using right now.
So it is sheath or sheathless, sir?
No, sir, it is a sheathless burr.
Okay, sir.
I prefer using a sheath burr.
Manoj,
Drill on, please. Drill on रखो आप लोग. Drill on रखो जब तक मैं बोलता हूँ. So now we started drilling at the spinal laminar junction. Now since we are doing on a cadaver, the interlaminar space is open because the muscle tightness, natural tightness is lost. So
just drill लेना ये लेना स्टेप लेना
off please, off please. I'll just
खड़े रहेंगे अरे ये सेक्शन का भी चेंज
So this is the lamina, spinal
बंदा
lamina
यहीं रहो।
junction. Above will be the spinous process.
Oh, much better. Oh,
so while
thank you
drilling
so much.
lamina, one has to keep in mind you don't have to go too much in the isthmus or pars. I mean area of drilling from where you start and where you move, that is more important thing.
On, drill on रखो. Now what happens is when you're using a non-guarded drill, that is a non-hooded burr like I'm right now, I want it to be completely under my vision all the time. Like if there is a soft tissue in front, that is problematic for me. Off please. Drill on please. So the drilling has to start at the surface cortical bone. This is the spinal laminar junction, the inverted V, C, inverted U, whatever you want to call it. The scientific name remains the same. That is the spinal laminar junction. We continuously keep drilling from the spinal laminar junction, coming in laterally. C-arm ला सकते हो क्या एक बार? While I am working, can you bring the C-arm? थोड़ा सा C-arm का height उठा के लेके आएंगे, please. हाइट उठाइए सियाम का. I want to show where they are working. का drill on, drill नहीं रोकना है. आप सियाम लेके आइए अंदर प्लीज. लाइए प्लीज. नाउ टेक अ शूट प्लीज. बस टेक अ ऑफ प्लीज. ड्रिल ऑफ. नाउ टेक अ शूट प्लीज. पीछे लेंगे सियाम को.
तुम्हारी तरफ खींच लो थोड़ा.
अभी शूट लेंगे. सी थोड़ा नीचे लेंगे.
नीचे
नीचे लेंगे. और नीचे लेंगे. और नीचे लेंगे. आप बस अभी शूट देंगे. कैन यू सी?
Yes,
Can
yes,
you
it's very well
appreciate?
seen.
My scope is able to. Once again, I just show it in a better way. अभी shoot देंगे please. See, my scope. I told you, the scope should be cranial and a little lateral to the working instrument, so that you can see things completely. ठीक है. सियाम हटा लेंगे please. RF क्वार्टरी पे कौन है? फुट प्लेट पे.
So this is the
Yellow,
cranial,
please.
This is the cranial and this is the caudal. So this is the
अरे अनूप.
lamina.
अबे उसको काम दिया था.
Off please. This is the midline, the spinous process over here. The lamina starting. Yellow please. Off please. Yellow.
Thank you.